Hey everyone, and welcome to the Module 3 Synopsis. Take a quick look at those module objectives, make sure you feel like you've met all of them, and if you haven't, see if there's anything that you feel like you need to go back and review. So tell me, which objective was the most difficult for you to achieve? Let me know. If we understand trauma a little bit better, we can understand trauma-informed care. Trauma results from an event or series of events, set of circumstances that are experienced by somebody that hurts them physically and emotionally, and it has lasting adverse effects. Sometimes those effects manifest in physical symptoms, and that's called somatization. So when we are using trauma-informed care, trauma-informed approach, we're using the strengths-based framework that acknowledges the prevalence and impact of traumatic experiences in clinical practice. It emphasizes physical, psychological, and emotional safety for the survivors and the health professionals. It also creates opportunities for the survivors to rebuild that sense of control and empowerment, or we also call that resilience. I know you guys have read the text and done the ATI modules, so I'm just going to hit on a couple of aspects of the abuse and the clinical manifestations and all of that here. It's important that you understand the difference between aggression and anger, because actions intended to harm others are aggression. They can be physical, psychological, or both. Everybody can experience anger, but aggression is the deliberate attempt to harm or destroy and is referred to as hostile aggression. Anger is an intense emotion, but it's not aggression. Adverse childhood experiences, these are potentially traumatic events that a child experiences before the age of 18. Some examples are violence, abuse, or neglect, a family member that attempted or died by suicide, observing violence in the home, or having an unstable or unsafe home environment. Risk factors associated with abuse, aggression, and violence are a history of violence, being the victim of a crime, witnessing abuse or violence, poor self-esteem, or inadequate coping skills, no presence of a positive role model throughout childhood, and adverse childhood experiences. Predictors of violence are an inability to control aggressive impulses, not being able to understand the consequences of actions, lack of remorse when interacting with others, and substance abuse. Another topic that goes along with this is the non-suicidal self-harm. This is described as intentional harming of self, and it involves things like cutting, which is the most prevalent, scratching, biting, carving words or designs into skin, burning, hair pulling, head banging, and any other self-inflicted destruction of body tissue. Unfortunately, this behavior that often starts in adolescence has occurred more and more frequently over the last 20 years. So we need to be aware of the self-injurious behavior and be able to identify that potentially this is a manifestation of abuse, violence, or aggression. Clinical presentations of somebody that is experiencing abuse, violence, or aggression can be the defense mechanisms. So we're talking about displacement and suppression, regression, things like that. When we start talking about crisis and disaster and its impact on human beings, it's very similar and actually is trauma. So some of the impacts of that are disorders, from reactive attachment disorder to dissociative disorder and PTSD. There are probably as many theories surrounding crisis, disaster, and trauma as there are around psychology and psychiatry itself, but a couple of note are Bowlby's attachment theory, which has to do with when the trauma occurs and its impact on the attachment the child has and the manifestations later in life. There's also the polyvagal theory. This has to do with nervous system and trauma. So a person's response to trauma is very specific, and it varies in severity and presentation. Manifestations vary. They can be physical, emotional, or psychological. And in this polyvagal theory, there are also stages that have to do with that, and those stages kind of depict or direct how the manifestations are going to come across. Speaking from an etiological standpoint, it's very much the etiology of trauma, but there are factors that result in an increased risk of experience violence, abuse, crisis, and disaster, and those are having a disability, living in an institution, living in extreme poverty, Being unaccompanied or separated from family, this includes migrants, refugees, and asylum seekers, facing discrimination, belonging to a marginalized population, living with other social and economic disadvantages, and being a woman or child. Some clinical manifestations that you might see are people have intrusive manifestations such as involuntary or distressing rages, thoughts, memories. There's persistent avoidance where they try to avoid these memories, negative thoughts, feelings, and mood when they're unable to remember or they block memories of the trauma. There are also arousal and reactive manifestations, which jumpiness, nervousness, sleep disturbances, aggressive behaviors. Then there's depersonalization, where people feel detached or separated from themselves. And there's derealization, which is feeling like the world around them is unreal, dreamlike, or distorted. It's important to note that the nurse's role is not to repair or resolve the client's trauma. So remember, as nurses, we deal with symptoms. Their symptoms are causing them an inability to live life to the fullest, and they are in distress quite frequently, if not constantly. So our primary role in caring for the client here is to be a therapeutic presence, build that therapeutic relationship, collaborate with the clients and their families. These relationships follow the principles of trauma informed care, and they will help provide a safe space for the client to begin to heal. There's a great table with an overview of defense mechanisms in subchapter 3.4 in your textbook, but we're just going to take a look at a couple. Conversion is one that we kind of talked about before. When anxiety caused by repressed impulses and feelings are converted into physical symptoms, like somatization. There's denial, where people deny these feelings or ignore them. Dissociation, when people feel disconnected uh, because of a stressful or traumatic event, or the feeling that the event is not really happening. Displacement is the unconscious transfer of somebody's emotions and reaction from the original source to somebody that is less of a target. This happens often in children, and a lot of times they will displace their anger and their lashing out onto their parents because their parents are a safe space. There is regression, where people return to a prior or lower state of cognitive, emotional, or behavioral functioning. Repression, where people take these painful experiences and unacceptable impulses and unconsciously exclude them from their consciousness. And then there's splitting, where people look at things and objects that provoke anxiety and put them in categories. They're either all good or they're all bad. All right, moving on to some communication. So, as part of your reading, you took a look at the ANA communication competencies, and I want to know which of the three competencies are the most vital to you? Which ones do you feel like are the most important? The nurse-client relationship is important in all realms of nursing, but it is particularly important in the mental health community as a mental health nurse or dealing with mental health patients. Your positive nurse-client relationship is going to be the basis for all of the care that you provide. The nurse-client relationship goes through phases, and a common framework for the first phase, the orientation phase, is ADET, AIDET. So take a look at that and then move through the rest of the orientation phase, then into the working phase and the termination phase. It's incredibly important that you understand the breakdown of a nursing diagnosis, not because you're just going to be writing them all day long as a nurse, but so that it gives you a framework to think through a problem. These are judgments regarding the client's response to health issues or life experiences or their susceptibility. It's a way to understand what's going on with the patient, what the cause is, what your assessment showed, and then you can move into planning, interventions, outcomes, all of that. So just remember that a nursing diagnosis is the problem. It's related to the cause or etiology. The evidence is the signs and symptoms that you have gathered from your assessment and in reviewing the patient's history, chart, and all pertinent data. It's vital that when you're prioritizing problems for your nursing diagnosis or otherwise, that you take a look at Maslow's hierarchy of needs. When we're talking about medical surgical nursing, it's always ABCs, airway, breathing, circulation, and of course that's the same across all disciplines. However, it's a little bit more nuanced when you're looking at mental health problems. So you want to make sure that when you're prioritizing, you still start with those physiological needs, then move to the safety needs, then love and belonging, esteem, and self-actualization. It's very important to understand this hierarchy, and it's okay if you need to take a look at it when you're comparing what's going on with the patient to what you think needs to be the priority. To begin to understand therapeutic communication, it's important that you start identifying therapeutic techniques. Chances are you're using these therapeutic techniques already, so it's important for you to identify when you're using them, if you're using them in the correct context, and take a look at the definitions and examples. There's a great table in your text, Chapter 2, Table 2.3, that goes over these therapeutic techniques in detail. Right after the table in Chapter 2, 2.3a, there's 2.3b, and that goes over non-therapeutic responses. Most people don't use non-therapeutic responses intentionally. They don't understand that it's non-therapeutic and the impact that it can have on the patient, especially things like asking why questions or showing sympathy. Sometimes it seems like those are well-placed responses. However, they are not therapeutic, and take a look at the table in your text and get a good idea of why and some examples. There are numerous barriers to therapeutic communication. So I want to ask you, what are 2 barriers to therapeutic communication that you have seen in action? Luckily, where there's barriers, there are tips. So another question for you. If you were giving another student advice, what 2 tips for effective therapeutic communication would you recommend? Once a situation starts escalating, the priority becomes safety. So the nurse's top priority and the focus is no longer on therapeutic communication. So some signs and symptoms of escalation: voice pitch change, voice tone, voice volume, clenching fists, sweating, grinding teeth, gritting teeth, angry expression, those sorts of things. When you recognize an escalation, focus on priority. You're no longer focusing on the therapeutic communication part of your interaction. Motivational interviewing is very pertinent when it comes to patient education and health promotion. So, this is a communication skill that elicits and emphasizes a client's personal motivation for modifying behavior to promote health. There are some principles that you are guided by in motivational interviewing: expressing empathy, highlighting discrepancies, adjusting to resistance, understanding motivations, supporting self-efficacy, and resisting the reflex to provide advice. Those are some of the basic tenets of motivational interviewing. Always remember also, when you are employing this technique, that there are stages of behavioral change. There's the pre-contemplation, when they're not considering change; contemplation, when they're ambivalent; preparation, when they're taking steps towards change; action, when they're actively involved in change; and maintenance, when they're sustaining the targeted behavior. If you can identify the clients that are ambivalent about making a change or following their treatment regimen, you can listen for phrases yes, but, sighs. In any case, when you're using the motivational interviewing technique, it's important to understand which stage of behavior change the patient is, so then you can tailor your motivational interviewing style towards the specific patient. Speaking of the principles of motivational interviewing, what was one principle of motivational interviewing that stood out to you? Teletherapy and telehealth. This is the use of digital technology to deliver medical care, health education, and public service by remotely connecting multiple users in a separate location. So, who? You can use telehealth with the mental health population. Telehealth is also pertinent in medical surgical care, a lot of times for follow-up. So, what is it? Well, teletherapy can be telephone, or it can be virtual using video and audio. So, where is teletherapy and telehealth? Everywhere. Just about every provider offers some form of teletherapy and telehealth. It has particularly been used in mental health since the crisis of the pandemic, when there was a surge in mental health needs and a limited ability to see providers. So, when teletherapy and telehealth is scheduled, there's not normally just open groups for you to come in and out of. However, it can be done in large groups, small groups, individually, and otherwise. So there's a few guidelines for group therapy telehealth sessions, because it's important that the participants are pre-screened and This is because people have various needs, and we don't want the experience to either re-traumatize or trigger or otherwise be completely unhelpful. We also need to make sure that there's been a completion of an online consent form. Your group, should you be doing teletherapy groups, need to have guidelines. Select your setting, choose a platform, decide what sorts of aspects of technology are going to go into this teletherapy or telehealth session. And then lastly, be engaging. When you're on the screen instead of in person, it's even more important to be conscious of the group dynamic and take steps to keep group members interested. That's it for the Module 3 synopsis. Fantastic work, everybody, and keep going.